That's perfect. And actually, I'm really, really happy that you brought up the idea of MRD or measurable residual disease, as honestly, the next three questions have to do with MRD. This is for Dr. Cooperrider and Dr. Zhang. I think one overarching question prior to the specific patient question is, what does MRD mean to you? How do you assess for it? Is it going to be different in your diseases? Because the questions are the following. One, do multiple myeloma patients have MRD negative for many years? For lymphoma, do you apply MRD negativity to T cell lymphoma patients during treatment periods? Do you test MRD negative for lymphoma by mass spectrometry? And are there MRD tests for follicular lymphoma? So I think that there's a lot to tease out there about MRD and multiple myeloma and lymphoma. I don't know if you guys have, I'll let Dr. Cooperrider speak first, actually.
Okay, so I talked about how we do MRD testing pretty frequently from the bone marrow, which seems to have actually does have some prognostic significance that may even be better than our older traditional response criteria that we've been using. And so we kind of use it alongside our typical response algorithm to understand how deep the patient's response is. And they talked about sort of can they be negative for many years? Patients can be negative for many years. And actually, the prognosis that has even more prognostic value when patients have sustained MRD negativity. And so that can happen. And then, we use mass spectrometry sort of on a research basis right now. This question, I think, was specifically about lymphoma, but that we use it in the peripheral blood in myeloma to get a deeper understanding of whether there's protein circulating. And so we use that sometimes alongside our response assessment, though in terms of having enough data to use it for decision making in prime time, we probably don't have enough data to do that totally yet. But sometimes I think, it could be used alongside other modalities as part of a multimodality assessment of depth of response.
Great. Actually, maybe take a step back if either of you can answer. What is mass spectrometry? And it's really interesting that you mentioned it's in research. Why would one prefer that over the current standards?
Um, so mass spectrometry basically uses ionized molecules. You sort of like use
Yeah, this is very difficult, isn't
yeah, I'm like,
it?
are there any scientists on this call? They basically use like the mass to charge ratio to identify specific protein combinations. Maybe somebody else can even answer this better than I can. But basically, what it allows for peripheral blood testing of residual disease that's more sensitive than what we have with our current kind of SPEP and immunoglobulin assessments. And so we can understand from the peripheral blood, so the marrow obviously being the most sensitive for myeloma, but deeper peripheral blood could maybe help us forego some of those marrows if we could get a deep enough assessment in the blood. And so mass spectrometry allows for some of that. And I do think, in combination, it again kind of improves some of the prognostic abilities of our testing.
Okay, perfect. And then circling back to the lymphoma questions, Dr. Zhang, do you apply MRD to T cell lymphomas? And are there any MRDs for follicular lymphoma?
Okay, so well, for spectrometry, it's a protein testing, so we don't really use it in we don't really use it that much in lymphoma. We usually use DNA-based testing. Do I apply MRD testing to T cell lymphoma? So this is such a great question. So it's hard to answer. I think there is utility of MRD in T cell lymphoma, especially after patient complete that initial induction chemotherapy to decide on whether we consolidate, what do we consolidate with, what type of stem cell transplant we do. But all of those, but we don't have a perfect MRD test on market right now for T cell lymphoma. We have a couple ones, but they're we don't know specific cutoff, right? Like every time we talk about MRD testing, we're talking about cutoff. You can have no disease at all, right? Or you can have a little bit disease, or you can have a lot of disease, right? And then when we say someone is MRD negative, we just pick a level of very minimal disease cutoff. But still, there are some patients still might have disease, right? And then that little bit disease doesn't matter. How much does it matter, right? Because ultimately your immune system can potentially take care of very little disease. So in T cell lymphoma, I don't think we have the test, a perfect test yet, and we don't know the cutoff very well. But on the other hand, I do MRD testing on my T-cell lymphoma patient, especially during chemotherapy, and that's on a study. So the decision where I make the decision is that after treatment for lymphoma, if you guys, sometimes you can have a little bit PAT positive, right? Like it can be in the hilar lymph node, it can be somewhere it's really hard, and then you just keep biopsying, but you just don't see the disease. And then you're wondering if that's the disease, that's inflammation. So I think MRD testing can really help figuring out if that's the inflammation or disease. And for T-cell lymphoma in particular, about peripheral T-cell lymphoma or TFH lymphoma, so very specific subtype, I think you really have to reach to an MRD negative in order to benefit the most from autologous stem cell transplant. I think there's a study out of MGH looking at MRD testing. Almost all the patients with MRD positivity end up relapsing if they don't if they underwent autologous stem cell transplant. So that's a transplant from your own blood. But that's in a research setting, and we don't have a lot of patients. I think that study has like 10 patients or something. So I think it's a very promising field really for T-cell lymphoma. I test it so I can gain some knowledge. I tell my patient, don't look at the numbers, I will interpret it for you. So that's that. And then MRD test for follicular lymphoma. So I do MRD testing for follicular lymphoma, but only in early stage, like extremely early stage 1, and my goal was cure. Remember, the paradigm of follicular lymphoma is that we do not think follicular lymphoma can be cured no matter what you do. From the historical data. But for patients that have very early stage, you can potentially cure with radiation, plus minus a little bit rituximab. So those patients, I do MRD testing. I think the MRD negative give me a little bit more confidence of cure. That hasn't been shown in the literature, but it does give me that more confidence. But MRD testing in general is not covered for follicular lymphoma. We usually use it for diffuse large B-cell lymphoma and mantle cell lymphoma. But I think there's definitely utility. But remember, for non-curable disease, the MRD, like just repeated testing add to the cost, and you're not changing what you do. Follicular lymphoma, you can wait a long time before you start treatment. So that number going up and down, to me, if we keep testing it, just cause more anxiety than anything else. Yeah.
Yeah, that makes a lot of sense. And that's great that you're looking at MRD and research to ask and answer the question of what does this mean? What is it related to? So more to come.